A 45-year-old woman presents to the clinic complaining of weakness that progressively worsened over past 2 weeks. She states she had hard time lifting both arms, but they function normally. She notes no history of trauma, other deficits, or on examination. The patient has 2 out of 5 muscle strength on the shoulder shrug and arm abduction bilaterally. There is no other neurological findings that are not other neurological findings are normal. You notice some skin changes and ask the patient about it. She stated there is a rash around the eye as well as on the lower face. She's and going down on her neck and chest. She notes there is a rash started on the same side as the weakness began. Labs are drawn and complete blood count and basic metabolic panels are normal. So what is the diagnosis in this patient? And what is the two signs that are very pathognomonic for this patient? Yes, the answer is dermatomyositis, and the patient having rash around the eyes, it's called heliotrope rash. And Bruton's papule. Okay, so this patient having rash around the eye. So let's see. As other options that does not usually have any kind of rash, so we can rule out this diagnosis. So let's see, you can see the patient having rash around the eye here, and they can have a Bruton's papules here, and they have a rash that is like shawl. Someone put a shawl around the neck and back. So this is the kind of rash they have. So what is the clinical features to diagnose dermatomyositis? So the patient usually they have proximal symmetrical weakness, and there is a weakness in upper extremities and lower extremities, both are equal. The skin findings are Bruton's papules and heliotrope rash. What are the extramuscular findings? Extramuscular findings are interstitial lung diseases, patient having dysphagia, and myocarditis. Diagnosis is usually with increased creatine phosphokinase, increased CPK, increase in aldolase. Remember, aldolase is also increased, and increase in LDH. Patient have anti-RNP antibodies or anti-Jo or anti-MI2 antibodies. If you are diagnostic uncertainty, we can do electromusculography, or we can do a biopsy of the skin. So in the biopsy of the skin, you can see they will have a connective tissue sheet inflammation around with CD4 T cells. While in polymyositis, that is the same thing that presents same as dermatomyositis, but minus the rash, they will have CD8 positive T cells, while in dermatomyositis they have CD4 positive. And what is the treatment for this patient? We give high dose corticosteroid, plus we give them corticosteroid sparing agent, and we screen for malignancy, because this kind of dermatomyositis is a paraneoplastic syndrome, which is this diseases usually presents as malignancy progresses. So dermatomyositis is autoimmune diseases which causes symmetrical progressive muscle weakness, and that causes inflammation of perimysium of muscles with CD4 T cells. Okay, let's discuss two more important things we have to, as we seen in this question. One of them is myasthenia gravis and another one is Lambert-Eaton syndrome. Remember, myasthenia gravis is progressive, or it's having decrease in acetyl receptor at postsynaptic membrane. So the way to remember this is, this patient with myasthenia gravis, usually they will come in the late evening, and they will have fatigue, they will have ptosis and diplopia, and they will have muscle weakness, because as we as the day progresses their symptom gets worse. While Lambert-Eaton, they'll have progressive muscle weakness in the morning, but by the evening time they will have very less symptoms. So the patient who is having early morning weaknesses in suspension of presynaptic membrane, like this patient, is usually Lambert-Eaton, and it's due to presynaptic voltage gated calcium channel, and they have absent deep tendon reflexes. It can involve cranial nerve, and there is autonomic dysfunction and proximal muscle weakness. So remember these two things you have to remember. The patient presenting, like the nurse presenting at evening time after working full day, she is having ptosis, diplopia, dysphagia, dysarthria, symmetrical muscle weakness. So this can guide you to us to have myasthenia gravis. While the patient who is having Lambert-Eaton, who is a 50-year-old man, is having morning weaknesses and absent deep tendon reflex, or having lung cancer. So lung cancer can produce this type of antibodies against this presynaptic channels, and this can cause them to have a paraneoplastic syndrome, while myasthenia gravis is associated with thymomas. So we have to remember this kind of associations. Thymoma is associated with myasthenia gravis, and Lambert-Eaton is associated with a small cell lung cancer.
Thanks for watching. Please give a thumbs up and subscribe for more.